Okay, welcome everybody to the Women in Lymphoma, the second in our series of the WiLing Wednesdays and on the educational aspects of lymphoma. And today we're going to talk about lymphomas that are a bit more common in Asia. Last week we heard about some of the North American ones, and we want to be complete and talk about some of the rest of them as well that in North America we don't see very often. I'd like to thank our sponsors, MSD and Roche, who are helping to support this series. And we're very honored today to have two excellent speakers. We'll definitely looking forward to hearing their talks. We'll have some time at the end also for questions as well. So our first speaker is Dr. Ng Siok-Bian, and she is from the Yung Lu Lin School of Medicine, National University of Singapore. She's an associate professor in Department of Pathology, and she obtained her medical degree from National University of Singapore and fellowship at the Royal College of Pathologists in Australia. She completed her specialty training in hematopathology as a visiting fellow at the National Cancer Institute. And her research is really interested in EBV-associated T and NK cell lymphoproliferative disorders, and that is what she's going to focus her talk on today. I'm sure she'd be willing to answer some other questions as well. So I'm going to turn it over to you if you want to share your screen, and we'll go ahead with the first talk. Thank you so much.
Okay, I will try to share screen, but we try again. I'm not able to share screen somehow.
Anna, can you help out?
Can you, down the bottom of the screen, the share green
Yeah,
button?
I click on that and it says it's disabled.
Okay, try again, please.
Okay, great.
Excellent. And then full screen, please. Thank you.
Okay, there we go. We've got it. Thank you.
Thank you. Thank you very much for inviting me to share my experience. And today I would like to talk about the diagnosis and classification of EBV-associated T and NK cell lymphoproliferative disorders. And so while these group of disorder is rare, they are nevertheless very important because they're all quite aggressive diseases with a high rate of mortality. And they are prevalent not only in Asia, but we can also see them in Mexico and some parts of Central and South America. Many of them present with hemophagocytic lymphohistiocytosis as a clinical manifestation. And the challenge is that they show overlapping histologic and phenotypic features. So sometimes it can be difficult to differentiate them apart. And so the disease definition is very heavily dependent on the clinical presentation, the site of involvement, and whether the patient is a child or an adult. So the group of diseases can be categorized based on their clinical behavior into malignant diseases as listed below. And there's also a group of disease which is more indolent with more variable outcomes, such as chronic active EBV infection. Lastly, there's also an entity known as EBV-associated hemophagocytic lymphohistiocytosis, which is not a malignant or neoplastic process. It's regarded as a hyperplastic or hyperinflammatory syndrome that is triggered by EBV. And so this slide shows the spectrum of EBV-associated T and NK cell LPD that can occur in adults and children. So on the left-hand side of the panel, you have a hyperplastic hyperinflammatory condition that is known as EBV-associated HLH. And on the other end of the malignant spectrum, we have very fulminant aggressive lymphomas and leukemias. And somewhere in the middle with more indolent behavior would include the chronic active EBV infection. And remember that all of these can present with HLH, which is essentially a clinical syndrome that can be diagnosed as long as 5 out of 8 of these criteria are fulfilled, including the presence of hemophagocytosis as illustrated in this picture here. Extranodal NK T-cell lymphoma in the past have been known as malignant midline reticulosis or angiocentric T-cell lymphoma. While the majority of these tumors are derived from NK cells, a subset can have a cytotoxic T-cell origin, and they affect mainly adults who presents typically with a nasal or a midline destructive lesion that can result in nasal symptoms such as obstruction, epistaxis, or even resemble sinusitis. So this is a nasal scope showing a crusting and ulcerative lesion involving the turbinates. Outside the nasal location, this tumor can also involve skin, soft tissue, intestinal tract. And the lymph node and bone marrow can also be involved when the disease becomes disseminated. The tumor shows a very broad cytologic spectrum, and the tumor cells, as you can see here, can be small cell looking, can be medium in size, or can be large pleomorphic and obviously malignant tumor cells. Necrosis and ulceration are common features, and angiodestruction or angiocentric growth pattern is very characteristic, as illustrated in this picture here, where you see this blood vessel that is infiltrated and surrounded by the neoplastic lymphoid cells. However, it's not always present, especially in biopsy samples. So for diagnostic pathologists, it is not uncommon to be faced with a nasal biopsy where it can be challenging to differentiate whether this is a reactive condition or a lymphoma. So we do look out for features that would favor or be worrisome for a neoplasm, such as the presence of architectural disruption, where you see a tumor infiltrate that is destroying mucosal glands, or where it invades bone, invades blood vessel. The presence of atypia, which is better seen in the deeper part of the biopsy, it's also an atypical feature, together with cells with clear cytoplasm and mitosis. So this is an example of a nasal biopsy, and it shows many reactive cells with plasma cells, lymphocytes, and eosinophils. So when you look at this, very few people would even think about lymphoma. However, in another part of the nasal biopsy, there are these expansile sheets of lymphoid cells where you hardly see any mucosal glands. So when the mucosal glands are being destroyed or displaced, then it's a worrisome feature. And on high magnification, when we look at the lymphocytes, they all look very small and bland looking, maybe just slightly irregular. However, many of them have this clear space, as I'm pointing out to you, surrounding the nuclei. And this is clear cytoplasm, which is not commonly seen in reactive lymphocytes. So when you see this, you must always try and exclude a malignancy. The diagnosis of extranodal NK T-cell lymphoma can be established when you can show the tumor cells to be CD3 positive, or when they have a cytotoxic phenotype. The two markers that we commonly do would be TIA1 and granzyme B. And also illustrated here, this tumor is strongly and diffusely positive for EBER, which is an in situ hybridization for EBV. So we need to show that the tumor cells are CD3 positive, cytotoxic, and EBV positive. CD56 may or may not be positive. And do we need to distinguish T-cell versus NK cell? In routine practice, this is really not so important because it has no prognostic significance. However, when you have an apparent case of extranodal NK T-cell lymphoma occurring in a child, not in an adult, and presenting with nodal disease or systemic disease, then one would have to exclude other causes of EBV-associated T and NK cell LPD. And in these contexts, the distinction of cell lineage, whether the neoplastic lymphocytes are of T-cell origin or NK cell origin, becomes very important. And this table lists the tests that we do or rely on to distinguish between T-cell lineage or NK cell lineage. Essentially, we can only make a diagnosis of an NK cell tumor after excluding a T-cell malignancy. In NK T-cell lymphoma, the virus exists in a clonal episomal form and expresses a type 2 latency pattern, because by expressing a limited pattern of viral proteins, it allows the virus to escape the host's immune surveillance. Plasma EBV levels are often elevated, and the clinicians will find this useful to monitor disease progress and response to treatment as well. So this is a picture that shows an overview of the genetic abnormalities that can occur in extranodal NK T-cell lymphoma, grouped according to the mechanisms of functions. And over the years, many omics studies have reviewed the genetic alterations that happen in extranodal NK T-cell lymphoma, including mutations, copy number, aberrations, and epigenetic changes, commonly hypermethylation of promoter regions, that allow the tumor to either sustain proliferation, such as activation of the JET-STAT pathway and NF-kappa B, or allow the tumor to evade growth suppressor, with the loss of known tumor suppressor genes such as PRDM1 and FOXO3. And the mutation of TP53 is common in NK T-cell lymphoma, and it can enable the tumor cells to resist cell death. I'm not an expert in the treatment of NK T-cell lymphoma, but just to say that this tumor, there isn't really very much consensus in the treatment of NK T-cell lymphoma. But what we do know is that conventional anthracycline-containing chemotherapy is ineffective. The tumor responds better to L-asparaginase-containing regimens. So patients with limited stage disease are often treated with combination chemoradiotherapy, whereas those patients with more advanced disease are treated more aggressively with SMILE chemotherapy or stem cell transplantation. So this is a slide to show some of the more promising potential therapeutic targets that may be useful for NK T-cell lymphoma in the future. We know that the activation of the JAK-STAT pathway and NF-kappa B pathway activation can be targeted by a variety of small molecule inhibitors, and antibody-based therapy against overexpressed proteins such as PD-L1, VEGFR, and CD38 are also currently under evaluation in clinical trials. So hopefully in the near future, we will see more options available for the treatment of this tumor. Now, EBV positive peripheral T-cell lymphoma is very uncommon and is primarily a nodal-based peripheral T-cell lymphoma that occurs in older adults. They can be immunocompromised, and this tumor shows many similar features with extranodal NK T-cell lymphoma and can be challenging to distinguish from extranodal NK T-cell lymphoma. However, EBV positive PTCL are more often of T-cell origin. They are often CD8 positive, 56 negative, which is in contrast to NK T-cell lymphoma. They have primary nodal presentation, and they often lack nasal involvement. Because data on EBV-associated PTCL is currently limited, and it is unclear if this represents a distinct entity, so the latest WHO classification recommends to just regard this as a variant of PTCL-NOS until further data is available. This is an example of an EBV positive PTCL occurring in a 55-year-old man. The lymph node was enlarged and biopsied and showed effacement of the architecture, and clearly there are malignant large-looking lymphoid cells here. These tumor cells are positive for CD2, CD4, and TCR beta, which establishes the T-cell lineage of this tumor, and the tumor is very positive for EBA as well. Aggressive NK cell leukemia is defined as a tumor of NK cell origin that primarily involves the peripheral blood and bone marrow, and patients often have a very aggressive clinical course. While it is again quite similar to extranodal NK T-cell lymphoma, there are certain features that are different in that the patients are usually younger. They can even affect children or young adults who often presents with systemic disease rather than tumor mass and HLH. They have more frequent loss of 7p and 17p region and mutation of the RAS and MAPK pathway, and patients often die very quickly with multi-organ failure and disseminated intravascular coagulopathy. In the peripheral blood and bone marrow, we will see variable numbers of atypical lymphoid cells as illustrated in this picture here. They are large granular lymphocytes with cytoplasmic granules. In tissues, there will be infiltrate that can be monotonous or with variable degree of atypia. And here we see an example of a 60-year-old man with end-stage renal failure, and he had persistent NK lymphocytosis in the acidic fluid. This is the bone marrow biopsy showing atypical lymphoid proliferation that is CD3 positive, CD56 negative. It's cytotoxic as illustrated by TIA. And this double stain for EBV and TCR beta shows that the brown the brown color stains the EBV in the nuclei, and these cells are not positive for the red color stain, which highlights TCR beta. So this shows that the tumor cells are most likely NK cells rather than T cell in origin. And in the bone marrow, we could identify hemophagocytosis. This is a histiocyte containing many blood cells within the cytoplasm, as well as many atypical lymphoid cells. A karyotype was done, and it showed the deletion of chromosome 6q21 region, which is commonly reported in aggressive NK cell leukemia. Systemic EBV positive T-cell lymphoma of childhood is a monoclonal proliferation of EBV-infected T cells, and it can occur in two settings. One is in a setting of a primary acute EBV infection, or it can occur in patients with chronic active EBV infection. Again, very similar to aggressive NK cell leukemia, the patients often have a very fulminant disease and die very quickly of multiple organ failure or DIVC. So in a setting of a primary EBV infection, patients are usually previously well, and they suddenly come down, get infected with this fulminant disease, and they die very quickly within 1 or 2 months. For those patients with a history of CA-EBV, the onset of the disease can be a bit slower, but nevertheless, most of the patients still die of disease within a year. In terms of pathology, it's quite variable. The degree of atypia and the number of infiltrating lymphocytes can be variable. Usually, we will be able to demonstrate hemophagocytosis in either the bone marrow or other organs. There may be a sinusoidal or portal lymphoid infiltrate in the liver or spleen, and the number of EBV positive cells can be variable as well. T-cell monoclonality can usually be demonstrated if you do a PCR for clonality. This is an example occurring in an 18-year-old man. He presented with symptoms of HLH and fever, and the lymph node biopsy was performed, which shows disruption and effacement of the architecture. And on closer inspection, there are atypical looking lymphoid cells here. They are quite large with prominent nucleoli, and they are positive for CD3, CD8, and TCR beta, which again indicates that these abnormal lymphocytes are of T-cell origin. And of course, they are strongly positive for EBV as well. Coming to chronic active EBV infection, the indolent group of diseases, CA-EBV is defined as a systemic and polyclonal T or NK cell proliferation. So in order to establish this diagnosis, we need to show that there is evidence of organ involvement for at least 3 months in duration. Patients often present with infectious mononucleosis-like symptoms. They have high viral load in the peripheral blood or tissues, and there must be no known underlying immune deficiency. The median age is about 11 years old, and patients can present with symptoms of HLH. They can have enlarged lymph nodes, or they can have cutaneous lesions, such as hypersensitivity to mosquito bites, hydrovasiniformy, eruptions, or blisterings, or some non-specific skin rash. Morphology is again variable, and sometimes you can have a polymorphic infiltrate, meaning that there are many inflammatory cells in the background, and sometimes this can mask the presence of neoplastic cells. CA-EBV can be derived from cytotoxic T cells or NK cells, and when you do T-cell receptor gene clonality assay, they are usually polyclonal or at most oligoclonal. These patients are treated with the HLH protocol, which is illustrated on the right-hand side, combination of dexamethasone, etoposide, cyclosporin A, and intrathecal prednisolone and methotrexate. However, they have a high risk of progression to more aggressive T or NK cell lymphoma and leukemia. This is an example of a bone marrow biopsy, and actually based on this image, it's very difficult to make out the neoplastic cells. And even when you do just a T-cell, pan-T-cell marker such as CD3, it doesn't look very impressive. There is an infiltrate, but the numbers are not very remarkable. But once you do EBV stain, you can definitely see the abnormal EBV positive cells present in a bone marrow, and you should not have, normally you shouldn't have EBV positive cells in a bone marrow. Cutaneous CA-EBV, such as severe mosquito bite allergy, it's a condition characterized by an NK cell lymphoid infiltrate that is activated by mosquito bite. Very uncommon. In fact, we don't also commonly see this condition in Singapore. Most of the cases reported in the literature comes from Japan and Korea, some from Taiwan and Mexico. The patients usually will present in the first 2 decades of life. They have high EBV viral load, they have high IgE and maybe NK cell lymphocytosis as well. So the clinical presentation is very characteristic. After being bitten by a mosquito, they would get this very intense local symptoms such as they get erythema and bulla formation, and then it will become a necrotic ulcer and subsequently heal with scar formation. These patients may have systemic symptoms like fever, lymphadenopathy, and the clinical course is variable. Some may go on to develop systemic features of CA-EBV. Some may progress to more aggressive NK or NK cell lymphoma or leukemia. So this is an example in our local case, 14-year-old female giving a history of developing some skin ulcer that became necrotic after being bitten by a mosquito. So you can see it's covered by this black necrotic slough in the center. And when we examine her, she also has other skin lesions, looking at these very depressed looking scars, evidence of previous lesions, similar lesions that is triggered by mosquito bite. And in the tissues and blood, we could show that there were abnormal lymphoid cells that are CD3 positive, that's marking in red, and they are also co-expressing EBV in the nuclei. Hydroxyvaccininform-like T-cell, hydroxyvaccininform-like LPD is also a cutaneous manifestation of CA-EBV, and it can be of T-cell origin or NK cell origin. So this disease shows a range and a spectrum of clinical behavior and aggressiveness. So it can range from more benign or classic HV to severe HV to cases that resembles an overt T-cell lymphoma. And so because there is currently no reliable marker that can differentiate a classic from severe to a T-cell lymphoma, the current recommendation is to group all of them into this term HV-like LPD that encompass all of these lesions. Essentially, patients with classic HV have more benign self-limiting disease that's triggered by light, whereas those with severe disease have more extensive skin lesions that may no longer be triggered by light, and they can have systemic manifestations, and they often progress to more aggressive T-cell or NK cell malignancies, and these patients need to be treated more aggressively. Morphologically wise, the infiltrate is again variable, and the degree of atypia is variable. They can be derived from cytotoxic T cells or NK cells, and when you do a clonality test for TCR, they are often monoclonally rearranged. This is an example of a classic HV on the left-hand side with skin eruptions on the hand, and in contrast, very severe HV with very extensive skin lesions. And a skin biopsy would show a lymphoid infiltrate that is EBV positive. Lastly, EBV-associated hemophagocytic lymphohistiocytosis. As mentioned, this is not a neoplastic condition. It's a hyperplastic or hyperinflammatory syndrome that is triggered by EBV, and so the patient goes into a cytokine storm and manifests symptoms of HLH. Again, it can be derived from T cells or NK cells. Most patients would have a self-limiting disease and recover, although a minority of patients can still die of the disease, and they will die of the HLH most of the time. And although this is a non-neoplastic condition, T-cell monoclonality has been reported. So in this example, this patient was about 30 years old, and she came in with fever and some symptoms of HLH. A bone marrow was biopsied, and it showed an EBV positive T-cell infiltrate. However, within about two weeks of the diagnosis, the symptoms starts to resolve even without treatment. So we watched her and monitor her, and a repeat bone marrow biopsy about 4 months later showed that the EBV infiltrate in the bone marrow was no longer there. So this is an example of EBV-associated HLH. So this slide shows the list of tests and stains that we need to do in the diagnostic workup of any patients with EBV-associated T and NK cell LPD. And I would say and highlight that very, very importantly that in situ hybridization or EBV is a must for all these patients. Otherwise, you may miss the diagnosis. And we also need to do markers for T cell versus NK cell lineage. And karyotyping is also quite important. If you see karyotypic abnormalities, then it tends to favor a neoplastic condition. And lastly, I would like to share this very busy slide, but it's an algorithm that I find that's useful for myself to classify and diagnose patients with EBV-associated T-cell and NK cell LPD. So I'll just like to bring you through this approach. If you have an adult patient with EBV-associated T and NK cell LPD, we need to differentiate whether this patient is presenting with systemic disease with bone marrow and peripheral blood involvement, or is mainly presenting with tumor masses. So if it's the systemic disease and it's derived from NK cells, think of aggressive NK cell leukemia. On the other hand, if the patient presents mainly with masses, and if it's involving mainly extranodal sites coming from NK cell origin, think of extranodal NK T-cell lymphoma. If it's an adult patient mainly with nodal disease and derived from T cells, then you can consider the diagnosis of EBV-associated PTCL. However, in children or young adults, it's slightly different, although the clinical presentation is still very important. Those patients with mainly skin diseases that are triggered by mosquito bite and of NK cell origin, then consider severe mosquito bite allergy, whereas those that are triggered by light and can be of T or NK cell origin, think of hydrola vacciniforme like LPD. For children and young adults presenting with a systemic disease, the duration of symptoms is quite important. In patients with very fulminant acute disease, and depending on the cell lineage, they can be classified into aggressive NK cell leukemia or systemic EBV positive T-cell lymphoma of childhood. Patients with symptoms that last for more than 3 months in duration, we have to start thinking of chronic active EBV infection. And lastly, not to forget that we have this non-neoplastic hyperinflammatory condition that can present acutely, which is EBV-associated HLH. So before we diagnose a neoplastic condition, we should exclude a hyperinflammatory syndrome such as EBV-associated HLH. So lastly, some take-home messages. An accurate diagnosis of EBV-associated T and NK cell LPD really requires an integration of both of everything like your clinical features, morphologic, phenotypic, and genotypic findings. And remember, some malignant diseases may not have very obvious cytologic atypia. And also, T-cell monoclonality alone cannot distinguish reactive from malignant EBV-associated T and NK cell LPD because it can be present in reactive conditions as well. And because there's no absolute marker that is specific for NK cell origin, the diagnosis of an NK cell LPD is often dependent on the exclusion of other T cell malignancies. And we always need to have a high index of suspicion and be aware of this entire spectrum of condition so as not to avoid any misdiagnosis. And that is my last slide. Thank you very much.
Thank you so much for that great talk and really great cases and examples, some of which I've never seen, so that's exciting. We're going to go ahead and switch to our second speaker, and we'll take questions after both talks. So it's my pleasure now to introduce Dr. Qin Song, and Dr. Song and I go way back. She actually spent some time in Omaha, so Dr. Song is from Peking University Cancer Hospital in Beijing, where she's an associate professor of medical oncology and deputy director of the lymphoma department. She's also president assistant of Peking University Cancer Hospital. And her specialty really is looking at new therapies for lymphoma, clinical trials, CAR T cells, BTK inhibitors, and she's done a lot of the very important clinical trials that have been done at her cancer center. So we're looking forward to hearing about some of the more common T-cell lymphomas in China and talk about some of the treatments. So thank you again for doing our talk today.
Thanks for introduction. I'll try my slides.
You look great, thank you.
It's okay?
Yes, they look fine, thank you.
Oh, thank you. Thanks for Julie's invitation. It's my great honor to give a presentation of clinical management of peripheral T or NK cell lymphoma in China. I'm Qin Song from Peking University Cancer Hospital. First, I will give a brief introduction of the pathological subtypes and the prognosis of peripheral T and NK cell lymphomas in China, and then we'll focus on the first-line treatment, including induction therapy and consolidation therapy, especially auto stem cell transplantation. And finally, I will give an introduction of novel agents in China at present time, including no approved agents in China and also agents in clinical studies. The left figure shows data from the largest lymphoma pathology study in China. It was sponsored by the Chinese Lymphoma Pathology Cooperation Group in 2011. 110,002 lymphoma cases were reviewed and confirmed by the experienced hematological pathologists in more than 10 sites in China. 2,138 cases were diagnosed as T and NK cell lymphoma, accounts for 21% of all lymphoma patients. And the NKT cell lymphoma accounts for, as the top one subtype, accounts for 28%, and then followed by peripheral T-cell lymphoma non-specified 20%, and angioimmunoblastic T-cell lymphoma 12%. The right data is from our center, Peking University Cancer Hospital. 337 patients continued peripheral T or NK cell lymphoma patients were confirmed and reviewed. The NKT cell lymphoma nasal type is the most common subtype in my center, accounts for 46%, and then followed by the peripheral the angioimmunoblastic T-cell lymphoma 17%, and then followed by ALK positive and plastic large T-cell lymphoma 11%. As compared with the global data from the International Peripheral T-cell lymphoma project, NKT cell lymphoma is more common in China, especially in my center, and then followed by peripheral T-cell lymphoma non-specified and angioimmunoblastic T-cell lymphoma. From this year, supported by the Chinese government, the Lymphoma Investigators Union will review at least 30,000 of lymphoma cases in more than 50 centers in China. So we hope to get a more reliable data. As for the prognosis of peripheral T and NK cell lymphoma, I cannot get the exact national survival data from China, but these data are from our center from 1996 to 2015. 679 cases were diagnosed with peripheral T-cell lymphoma or NKT cell lymphoma were reviewed in my center, and the 5-year overall survival 50% and 10-year overall survival 41%. The ALK positive and plastic large T-cell lymphoma showed the best survival, and then followed by ALK negative and plastic large T-cell lymphoma and NKT cell lymphoma, angioimmunoblastic T-cell lymphoma and peripheral T-cell lymphoma non-specified showed the poorest prognosis. The 5-year overall survival was only around 30%. So our data is very similar to the global data. As for the first-line treatment, including induction therapy and consolidation therapy, according to the collection data from the Chinese Lymphoma Investigators Union, at least 90% hospitals will give CHOP or CHOP-like regimen as first choice, but only large hospitals can do stem cell transplantation. This data were also from Peking University Cancer Hospital. From 2009 to 2017, 116 newly diagnosed peripheral T-cell lymphoma patients received initial chemotherapy in our hospital. We tried 3 regimens, the CHOP-E and the CHOP-E gemcitabine-based regimen, such as GMOX or GDP alternating regimen. No, for these 3, for the 116 patients, 46 patients received CHOP, and 46 patients received CHOP-E regimen, and 24 patients received CHOP-E and G alternative regimen. No patient received auto stem cell transplantation as first-line therapy, and Among the patients, the median age was 57-year-old, and three-fourths patients with advanced disease and one-fourth with at least one extranodal site involvement. The major pathological subtypes were angioimmunoblastic T-cell lymphoma, active and plastic large T-cell lymphoma, and the peripheral T-cell lymphoma non-specified. Among the groups, except for the age, the basic characteristics such as gender, ECOG score, pathological subtypes, and RPS score showed no difference among these three groups. The overall response rate for CHOP-E and CHOP-E gemcitabine alternate regimen were 82.6%, 76%, and 75%, and the complete response rate were 32.6% and 56.5% and 50% respectively. Within a median follow-up time of 35.5 months, the 3-year overall survival of CHOP-E and CHOP-E-G alternating regimen was 37%, 47%, and 56% respectively, and the 3-year progression-free survival of CHOP-E and CHOP-E-G alternating regimen were around 20%, 30%, and only 5% respectively. So the CHOP-E regimen showed a better OS than CHOP and a better progression-free survival than CHOP-E gemcitabine alternating regimen. CHOP-E gemcitabine regimen had a higher incidence of anemia and thrombocytopenia. So CHOP or CHOP-E now is a popular or preferred regimen in my hospital. This is as for the auto stem cell transplantation, this is a relatively large number of auto stem cell transplantation as first-line consolidation therapy in peripheral T-cell lymphomas. 142 cases from 16 centers in China were analyzed. The estimated 5-year overall survival around 73%, ALK-positive and plastic large T-cell lymphoma and ALK-negative and plastic large T-cell lymphoma showed the best survival, then followed by NK T-cell lymphoma and angioimmunoblastic T-cell lymphoma. As for the time point for auto stem cell transplantation, this data was also from Peking University Cancer Hospital. 79 cases of peripheral T-cell lymphoma received auto stem cell transplantation were retrospectively analyzed in all centers. 52 patients as first-line consolidation and 27 patients after salvage chemotherapy. 4 patients in first remission, even in partial remission, showed a better 2-year progression-free survival with 84%. But for patients in the second complete remission or partial remission, the 2-year progression-free survival was only around 33%. And in the next several slides, I will focus on the most common subtype, NK T-cell lymphoma nasal type, because it's the very common disease in China. The CLCG is the largest database of NK T-cell lymphoma in China, including 400 cases from my center. From 2000 and 2015, we retrospectively analyzed 2,560 continued cases from 20 centers in China, 87% cases with localized disease. The median follow-up time was 4 years. For all patients received chemo without radiotherapy. The data showed that patients receiving non-cycling regimen acquired higher overall response rate and complete response rate, and improved 5-year overall survival and progression-free survival. But these advantages was mainly in patients with localized disease. For patients with advanced disease, their prognosis is still very poor, with only 30 of 5-year progression-free survival. So the Southern Lymphoma Study Group initiated a non-inferiority phase 2 study to compare PGMOX plus thalidomide versus Aspamate dexamethasone in NKT cell lymphoma patients. For patients with localized disease, 4 cycles or less chemo and then followed by radiotherapy. For patients with advanced disease or a refractory or relapsed disease, 6 cycles or less of chemotherapy and then followed by auto stem cell transplantation. These 2 regimens showed no difference in overall survival, overall response rate and complete response rate in patients with localized disease, but PGMOX showed a relatively high overall response rate in patients with advanced disease or relapsed or refractory disease. For the progression-free survival and overall survival, PGMOX showed no advantage. So due to the convenient application, PGMOX is more common applied regimen in China. And another lymphoma study group from central part of China initiated a phase 2 study to compare DDGP with SMILE regimen in newly diagnosed NKT cell lymphoma nasal type with advanced disease or local disease with poor prognosis. The DDGP includes cisplatin, gemcitabine, and pegase. And 8 patients were enrolled in the study. The median follow-up time was around 41.5 months. Because of the heavy toxic side effects and the higher treatment-related mortality of SMILE, DDGP showed improved 5-year progression-free survival and overall survival. In my center, COEP plus pegase, the COEPL is a long-applied first-line choice to all NKT cell lymphoma patients. For localized disease, we give COEPL 2 cycles and then followed by radiotherapy concurrently with LOP, pegase plus OP 2 cycles, and then followed by 2 cycles of COEP again. And then for advanced disease, we give the 6 cycles of COEPL and then followed by auto stem cell transplantation without radiotherapy. From 2014 to 2016, 8 patients were enrolled in this study. 64 patients with localized disease, the median age 41 years old, and the median follow-up time 41.4 months. For all patients, the complete response rate 75%, the overall response rate 84%, and the 3-year progression-free survival 71.3%, and the 3-year overall survival 73%. This regimen is quite safe and no patient cannot tolerate, so it's very tolerable. As for the progression-free survival and overall survival in patients with disease localized in head and neck or localized skin involvement due to the application of radiotherapy, COEPL plus radiotherapy acquired a 3-year progression-free survival of 78%, and the 3-year overall survival 81%. But for advanced disease, even some patients followed by auto stem cell transplantation, the 3-year progression-free survival was only 48%, so it's not satisfied. So in my center, patients with disease outside head and neck or with advanced disease without the possibility of radiotherapy will receive 6 cycles of COEPL for patients with and then for patients with complete or partial remission, will move on to auto stem cell transplantation. The conditioning regimen is TBI plus high dosage of cyclophosphamide. But for patients refractory to COEPL and the second line therapy of GDP, will be preferred to allo stem cell transplantation or in clinical trials. The last topic, I will focus on novel agents for refractory or relapsed peripheral T-cell or NK cell lymphoma in China. Qinmat is a new HDAC inhibitor. It's also the first novel agent approved for peripheral T-cell lymphomas in China. In this multicenter phase 2 study of Qinmat in patients with relapsed or refractory peripheral T-cell lymphomas, the TPL study, Qinmat showed an overall response rate 28% and the median progression-free survival 2.1 months and the median overall survival 21.4 months. And the second approved novel agent was brentuximab last year, and pralatrexate had been approved by FDA around 10 years ago, but it was approved in China just last year based on the data from the 301 study. In this multi-center study, single-arm study, it's a supported study for China NDA. 71 patients received pralatrexate, and the overall response rate was around 50%. But as compared with the Japan study and the global study, in all study, 20 patients with angioimmunoblastic T-cell lymphoma were enrolled. 11 cases acquired response, and also 5 relapsed NK T-cell lymphoma nasal type with relapsed or refractory disease were also enrolled in this study, and 3 patients with response. The median progression-free survival was 4.76 months, and the overall survival around 18 months. So pralatrexate has got the approval in China. As for the PD-1 or PD-L1 antibodies, clinical studies of PD-1 or PD-L1 antibody are also very popular in China, especially in refractory or relapsed NK T-cell lymphoma. Early studies just followed Professor Dr. Kwong's study regimen applied to PD-1 or PD-L1 antibody as single agent. The overall response rate were from nearly 17% to 30%, and the complete response rate from 40% to 18%, quite different. But at present time, the studies are usually in combination with Qinmat or chemo or other or novel agents with different mechanisms, such as PD-1 antibody camrelizumab, a PD-1 antibody with apatinib. Apatinib is a novel agent with multiple mechanisms. In this study, 15 patients with a relapsed or refractory peripheral T or NK cell lymphoma were enrolled. The overall response rate around 1/3, and the median progression-free survival was 5.47 months. This study is still ongoing in refractory or relapsed peripheral T and NK cell lymphoma patients in China. We also have several novel agents now in clinical trials, mostly in phase 1 or phase 2 study, such as a JAK1 inhibitor in peripheral T-cell lymphoma as a phase 1, phase 2 clinical study cooperating with Professor Kim in South Korea. And we also have several PI3K inhibitors and also BTLA antibody, CD47 antibody, and EZH2 inhibitor in relapsed refractory non-Hodgkin lymphoma, including peripheral T-cell lymphoma. And also for advanced or relapsed NK-T-cell lymphoma, we have investigator-sponsored multi-center study is ongoing. It was tislelizumab, a PD-1 antibody from BG, plus pegaspargase and azacitidine and dexamethasone. This study is ongoing. So in summary, NK-T-cell lymphoma nasal type and peripheral T-cell lymphoma non-specified and angioimmunoblastic T-cell lymphoma were more common in China. CHOP or CHOP-like regimen, especially CHOP-E, and are the preferred regimens in 90% hospitals in China. Auto or allo stem cell transplantation was only be given in large hospitals. So in China, less patients receive transplantation. From our center's data, auto stem cell transplantation as first-line consolidation therapy significantly improved the survival of patients in remission. And for NK-T-cell lymphoma nasal type, pegaspargase-based regimen plus radiotherapy showed satisfied survival in patients with localized disease. But for patients with advanced or relapsed refractory disease, more effective regimens need to explore and then followed by stem cell transplantation. Treatment, brentuximab and pralatrexate were not approved in China. More novel agents now just in phase 1 or phase 2 study. Thanks again for invitation and thanks for your attention.
Oh, thank you so much, Dr. Song. And we'll go ahead and get both of our speakers hopefully back on here and open it up for some questions. There is one question that was in the chat box here. Do you have a particular preference in which chemotherapy regimen to choose based upon the phenotype or the cell origin, either if it's NK or T cell phenotype? Oh, Dr. Song, I think you're on mute.
I'm sorry.
There you go. Now we're good.
The question.
The question was, do you have a particular preference on which chemotherapy regimen based upon the phenotype of the cell of origin? If it's a NK T cell, like if it's NK versus cytotoxic T cell phenotype.
Yeah,
any difference?
Yeah, for the NK cell lymphoma, we prefer the pegaspargase-based regimen for patients. For the patients with localized disease, we give the radiotherapy. But for patients with advanced disease, we give the auto stem cell transplantation with TPI plus high dosage cyclophosphamide as conditioning regimen. And for anaplastic large T-cell lymphoma are positive or are negative because brentuximab now has got approval in China. So BV plus CHP is also a preferred regimen for the anaplastic large T-cell lymphoma, especially systemic patient disease.
Yeah, I think the addition of brentuximab has made a big difference for those patients, for sure. There's another question here from Anne LeCase. Anne, I don't know, can you unmute to ask, or should I ask?
Sure, I just was curious as to whether you would consolidate ALK positive patients with autologous transplant in first remission. It seemed like those were kind of driving those very good outcomes with auto transplant.
Now, for ALK-positive and plastic large T-cell lymphoma, we only give auto stem cell transplantation as first-line consolidation therapy for patients with RPS score higher than 3 or 3. And not for all patients, because for patients with low RPS score, I think the prognosis is quite good.
Great, thank you.
And did that change any when you had the addition of brentuximab for those patients? Have you still gone to doing that for the higher risk patients with the BV chip?
You mean for BV?
For the anaplastic large cell ALK positive patients who have received the BV chip regimen relatively recently, are you still using auto transplant in first remission for those patients as well?
Now for the ALK-positive and plastic large T-cell lymphoma, because most patients, especially with low IPS score, the prognosis is quite good. So, and also brentuximab is very expensive in China and cannot be covered by the healthcare system. So we usually give the CHOP-E regimen, because for this group of patients were relatively young, and for the patients with high risk score, especially with 4 to 5 score. So maybe if the patient is rich enough, and we will give the BV. And also for patients with ALK-negative anaplastic large T-cell lymphoma, even with the brentuximab plus CHP as first-line treatment, we also give stem cell transplantation for this group of patients, especially with high score, IPS high score. Yeah.
Okay. Judith, I
So
see you
I just
on.
have a-
Thank you.
Sorry.
No, go ahead.
In response to Dr. Vo's question on whether lineage plays a part in deciding treatment, previously you have a question on that. So we know that in NK T-cell lymphoma, whether it's of T-cell or NK cell lineage, it doesn't really have any prognostic significance. So I think most of us do not make a difference in treatment, whether it's of T-cell lineage or NK cell lineage. However, having said that, knowing that extranodal NK T-cell lymphoma is often of NK cell lineage, I think the important thing to note that if you have one that's of T-cell lineage, then you have to be careful that some other differential diagnosis may be considered, and it might not actually be NK T-cell lymphoma. I think that's the thing to remember about lineage. At the moment, no prognostic significance and no therapeutic implications.
Thank you.
I just wanted to make a comment. I was actually quite heartened, Dr. Song, at the 33% 2-year progression-free survival for salvage transplant consolidation in your PTCL population, given that they would have been probably, huge selection biased and not chosen to go on to transplant in the first line setting, probably presumably they were an older, less fit patient population, or so that's, I guess, just a comment. And then the other question, it's more a clinical practice question, a curious question about practice in China, particularly given your clinical trials. Do you cross-refer patients to other institutions for trials? I'm just mindful a lot of our Australian citizens have dual citizenship, and I'm sure a number of them who travel to China frequently pre-COVID, let's pretend we're not in a COVID situation, would happily go back to China to get access to some of these novel agents for their relapsed disease.
Yeah, because in China, about 2/3 of the clinical trials in lymphoma we are the leading site of the 2/3 of the clinical studies in China. And last year and before the year of the year before last year, all the lymphoma novel agents approved in China are from our group. So we have many clinical trials in our site. So if you have the Chinese patients in your country and they want to go back to China and receive clinical trials, yeah, you can ask me and or refer them
Right.
to our hospital by email or something. Yeah.
Well, that's fantastic, and it's wonderful you're doing so many trials, because we really are globally so dependent on you to lead us in this in Asia. Yeah.
Yes. Well, hopefully things will get back to normal and we can do those international studies and have our patients that need our services go back and forth. So soon. Are there other questions for any of our speakers today?
And I also want to give feedback to the question about the cell origin of T-cell lymphoma patients. Yeah, and for most of the extranodal T-cell lymphoma nasal type, most patients made their cell origin from NK cells. For the NK cell lymphomas, I think, yeah, PEX is very effective, but for the T-cell origin, I don't think the PEX is quite effective, because PEX-based regimen was first reported from our department in the year 2006. Yeah, we do know that for the T-cell origin cases, as PEX is not so effective. But it's very difficult to separate the cell origin, because for the pathologist, they just give us a diagnosis of T-cell lymphoma nasal type.
Thank you so much. I don't see any other questions. So thank you so much both for your great talks, and really appreciate you taking the time to do that today. And thanks to everybody for listening. We'd like to thank our sponsors, MSD and Roche, for helping us to do this international series as well. And we'll look forward to seeing you next week when we have our third talk in the T-cell series. And that's going to be Dr. Barbara Pro is going to be talking about relapsed treatment for relapsed T-cell lymphoma. And then Dr. Neha Mehta Shah is going to talk about autologous and allogeneic transplant for relapsed T-cell lymphoma. So thanks again, and great to see you guys. Bye.
Thank you.
Have a good night.
Bye.
Bye.